Hello, everyone. Welcome back. Let's start with a question. A 59-year-old man with long-standing rheumatoid arthritis presents with worsening fatigue and ankle edema. Lab show elevated ESR-CRP, which is our inflammatory marker. There's also 4 plus proteinuria. 4 plus proteinuria suggestive of nephrotic syndrome, whereby patient is losing a lot of protein from the urine. There's also elevated serum creatinine. A biopsy of the kidney shows Congo red positive deposits. As you know, Congo red is what we use for amyloid, right? When we're looking for amyloid in the tissue. Um, Derived from acute phase reactant. Which precursor protein is responsible for this? So based on the history of long-standing chronic inflammation with evidence of nephrotic syndrome, and we did a biopsy and a Congo red positive. So this patient likely have serum associated amyloidosis, and the best answer there will be C. Let's see why. So in today's lecture, we're going to be covering amyloidosis. So what's amyloidosis? So amyloidosis, they are a group of disorders that are characterized by extracellular deposition of misfolded proteins. And these misfolded proteins are aggregated into what we call beta-plated sheet structures, forming amyloid fibrils that damage the tissue. So what are these beta-plated protein, or what are these beta-plated structures? So they're actually a secondary structure of proteins. And this secondary structure of protein, these beta-plated sheets are very rigid, ideal for structural scaffold, and they could form amyloid fibrils, which is what's the problem in amyloidosis. Remember, as opposed to the alpha plated sheets, which are more flexible. And when this amyloid accumulates, they lead to organ dysfunction. And how do they cause organ dysfunction? Through pressure atrophy. So wherever they accumulate, they increase the pressure there, and that could lead to atrophy. And they could also activate apoptosis. And from our lecture of apoptosis, which of the pathway of the apoptosis do they activate? Very good. They're going to activate the intrinsic pathway. And these deposits are Congo red positive. So Congo red is the stain that we use, right? And they're going to stain positive for it. And then when you put them under polarized light, they're going to appear as apple green birefringence. So when we look at different type of amyloidosis, so we have systemic amyloidosis and we have organ-specific amyloidosis. And guys, these are high yield for the exam. So let's start with systemic amyloidosis. So under systemic amyloidosis, the first type we're going to talk about is light chain amyloidosis. So this light chain amyloidosis is seen in patients who have plasma cell dyscarisis. And these are patients with, example, multiple myeloma, because as we know, multiple myeloma is a malignancy of what? Of the plasma cells. And these plasma cells are going to be producing tons of immunoglobulin, right? Remember, we call it monoclonal antibody. So just one single antibody production. And then when you look at the antibody, maybe in this case, maybe IgG, as you know, they are made up of both heavy chain and light chain, right? So they are made up of heavy chain and light chain. And if it's IgG, right? So the heavy chain could be gamma chain, whereby the light chain could be lambda or kappa. And then guess what? Because we're making a lot of immunoglobulin, we're going to be breaking down a lot of them too, right? And then those light chain from those breakdown of those immunoglobulins are going to be converted to what? Amyloid. So those misfolded light chains aggregate into amyloid and they deposit in the tissue. And this could affect a lot of organs in the body. So if it deposits in the heart, right, it could lead to restrictive cardiomyopathy, heart failure. If it deposits in the kidney, it could lead to nephrotic syndrome, whereby you have 3 plus proteinuria in the urine, and it could lead to renal failure. And if it deposits in the nerve, it could cause peripheral neuropathy, autonomic neuropathy. If it deposits in the GI tract, it could cause things like hepatosplenomegaly, malabsorption, diarrhea, hepatosplenomegaly. And if it deposits in the skin, right, those patients could have what? They could have periorbital purpura, right? It could also deposit in the tongue. They could have macroglossia in those patients. So classically for light chain amyloidosis, you're looking for somebody who have history of plasma cell dyskaresis like multiple myeloma and now having multisystemic manifestation. And on biopsy, Congo red stain positive and they show apple green bipharyngea. That means this patient is having what? Light chain amyloidosis. Very good. Moving on to the next type. The next type of amyloidosis is what we call serum associated amyloidosis. So what's going on in serum associated amyloidosis? This is due to chronic inflammation. And what are these examples of chronic inflammation? Example like rheumatoid arthritis, inflammatory bowel disease, or somebody who have chronic infection like tuberculosis or osteomyelitis. And what's this chronic inflammation doing? As we know, with any inflammation, there's going to be release of what? Acute phase cytokines. So acute phase cytokines will be released. And what are the examples of these acute phase cytokines? Interleukin 1, interleukin 6, right? TNF alpha. So these are all examples of acute phase cytokines. And particularly this interleukin 6 is going to go and stimulate the liver to start to produce what? Acute phase reactant, right? Or acute phase protein. And then one of those acute phase protein is the serum amyloid, right? And because we're producing tons of this serum amyloid, they're going to be misfolded. And then that will lead to what? Serum associated amyloidosis. And this could affect the kidney and it can lead to what? Nephrotic syndrome. So if you see a question on the exam, somebody who have underlying chronic inflammation and now having renal failure, always with evidence of massive proteinuria, you should be thinking of serum associated amyloidosis. And the next one there is dialysis-related amyloidosis. So in dialysis-related amyloidosis, this is due to accumulation of beta-2 microglobulin. So where's beta-2 microglobulin coming from? If you remember the shape of the MAC class 1, right? So when you look at the shape of the MAC class 1, right? Part of that shape is what? Is the beta-2 microglobulin. So when you look at the MSC class 1, so part of their shape is this beta-2 microglobulin. And ideally, the kidney normally helps us to clear this beta-2 out of our body. But if somebody have end-stage renal disease and they are on dialysis, they might not be able to clear this beta-2 microglobulin very well from their system. And this is going to accumulate, become misfolded, and this is going to lead to what we call dialysis-related amyloidosis. And this could accumulate in the joints and it can lead to carpal tunnel syndrome because of the compression of the median nerve in those patients. Moving on to the next type, which is hereditary familial amyloidosis. And this is mostly due to transthyretin mutation, which is ATTR mutation. And in this patient, remember this transthyretin is what we used to call prealbumin. And the prealbumin is produced from the liver. And because of this mutation, so this patient are making tons of this protein, and this could accumulate inside the heart. It can cause restrictive cardiomyopathy. It could also accumulate in the nerves. It can cause neuropathy and autonomic dysfunction. And then moving on to the next one, which is age-related amyloidosis. And this age-related amyloidosis is also called senile amyloidosis. We also call it wild-type amyloidosis. All those, they are all the same thing. Age-related, senile, wild-type amyloidosis, they are all the same thing. And this is also due to transthyretin deposition, and this is commonly in elderly patients. And what's unique about this on the exam is this usually affects what? The heart. So it can lead to restrictive cardiomyopathy. So if you see somebody who is elderly and they're having isolated restrictive cardiomyopathy, in other words, there is no nephrotic symptom, no neuropathy, just the heart that is involved, always think of senile amyloidosis, and it's going to be due to accumulation of ATTR in those patients. Very good, guys. And let's look at the pathogenesis of this age-related amyloidosis. So like we said, this is due to transthyretin and normally circulate as tetramer, right? And this, when this tetramer destabilize, then they form monomers and misfold, and this is what leads to the what? Amyloid. And that's why we have a medication that we can use to stabilize those tetramer, and this medication is tafamidase, and this stabilize those tetramer, preventing their dissociation. And this medication could be used for what? Age-related or senile amyloidosis. Now we've covered the systemic amyloidosis. So now we're going to focus on organ-specific amyloidosis. So the first one under organ-specific amyloidosis is Alzheimer's disease. And as we know, Alzheimer's disease is due to accumulation of beta amyloid protein, and this comes from our amyloid precursor protein. And remember, this amyloid precursor protein, the gene is located on chromosome 21, and that's why in patients who have Down syndrome, remember, in Down syndrome patients, they have what? They have 3 of these chromosomes. So they have trisomy 21. And that's why those patients are going to be producing tons of this protein. And that's why they could develop early onset Alzheimer's. So in those patients, they could have early onset Alzheimer's disease in them. And this amyloid precursor protein, they are transmembrane glycoprotein, and they are found in the neurons, and you can also see them in the synapse and other tissue. And this a beta amyloid that comes from the amyloid precursor protein, they deposit in the brain. And then when you do autopsy on patients who have Alzheimer's disease, you're going to see them as senile plaques in the brain. Moving on to the next organ-specific amyloidosis, which is type 2 diabetes mellitus. In type 2 diabetes mellitus, as we know, is due to insulin resistance. So there's insulin receptor resistance. And then because of the insulin resistance, because of that, the beta cells is going to be making a lot of insulin. So that's why at the early stage of diabetes is usually what? Hyperinsulinemia state. So you're producing tons of insulin. And as you are producing the insulin, you're also releasing what? Amylin. So the amylin is also produced along with the insulin. And then guess what? This amylin could be deposited and be converted, misfolded, and be converted to amyloid. and that will deposit in the beta cell. And like we mentioned earlier, amyloid could trigger apoptosis, and with time, that will lead to destruction of those beta cells. And then with the destruction of those beta cells, those patients will now develop insulin deficiency. So that's why patients who have type 2 diabetes, initially, they could be non-insulin dependent. And then later, in the course of their disease, then they could develop insulin dependent diabetes mellitus because of the amyloid deposition. Moving on to the next one, which is medullary thyroid carcinoma. As we know, medullary thyroid carcinoma is a tumor that originates from the parafollicular C cells, and a parafollicular C cell produces calcitonin. And this calcitonin could be converted to amyloid, and they're going to deposit in the tumor stroma. And that's always a classic histology. So if you see somebody who have a thyroid mass, they did a biopsy and they did mention that they applied Congo red is positive, and they concerned about amyloid deposition, always think of medullary thyroid carcinoma. Who can remind us which gene is associated with medullary thyroid carcinoma? Very good. Ret oncogene. Very good. And as we know, ret oncogene mutation is associated with men 2A and men 2B. Very good, guys. Moving on to the next one, which is isolated atrial amyloidosis. As we know, anytime you have increased pressure in the atrium or increase in volume, so either increased pressure or increased volume, anything that stretch the atrium will lead to production of atrial natriuretic peptide. And this peptide could be converted to amyloid, and that could deposit in the atrium. So chronic atrial stretch or atrial fibrillation increase AMP production, predisposing to amyloid aggregation. And this amyloid aggregation in the atrium could actually worsen or contribute to the atrial fibrillation. It could infiltrate the SA node, thereby predisposing this patient to sick sinus syndrome. And that could also increase their risk of atrial thrombi, as we see with atrial fibrillation. And what are the clinical manifestations of amyloidosis? We've mentioned most of them already. So in the kidney, they could have nephrotic syndrome. In the heart, they could have restrictive cardiomyopathy, which can lead to diastolic dysfunction because the heart will not be able to relax during diastole. And when you look at the EKG, right, so you do your echocardiogram, right, the heart muscle looks really thick, right? But when you do your EKG, you see low voltage EKG, right? So thick myocardium, low voltage EKG. That's classic for restrictive cardiomyopathy. Remember, as opposed to hypertrophic cardiomyopathy, whereby you're going to also see thick myocardium, but in those patients, you're going to see what? High voltage on the EKG. And what does high voltage means? It means that the QRS, if it's a low voltage, the QRS will be very small. And if it's high voltage, the QRS will be very big. Very good. And in GI, they could have malabsorption, hepatosplenomegaly. And in neurology, they could have peripheral neuropathy, autonomic failure, or autonomic dysfunction. And in the skin, they could have periorbital purpura. We spoke about all those earlier. So now let's move on to diagnostic features that we see with amyloidosis. So let's talk about diagnostic features. So like we mentioned earlier, Congo red staining is what you're going to use. And what you're looking for on Congo red, you're going to see pink or red, as you can see in this biopsy. And then when you now put the Congo red staining under polarized light, then they're going to appear as apple green biphalange, as you can see on this imaging. And in patients who have light chain amyloidosis, in those patients, you can also do serum or urine protein electrophoresis, thereby looking for those monoclonal antibody, right? And this is high yield, guys. How can you make a diagnosis? So easiest way to make a diagnosis, you can do abdominal fat pad biopsy, whereby you're looking for those deposition of the amyloid. That's always high yield for the exam, guys. And of course, other places you can do biopsies, renal, rectal, organ biopsy. So now let's move on to talk about treatment. So let's talk about treatment for amyloidosis. And as you can expect, the treatment will depend on what type of amyloid, right? So let's start with the light chain amyloidosis. So with this, you want to treat the plasma cells, so treat their multiple myeloma, right? And you can also use what we call bortezomib, which we're going to talk about in a second. You can also use cyclophosphamide, dexamethasone, and you can do stem cell transplants. What about serum associated amyloidosis? So this one, you have to focus on treating the chronic inflammation. So treat the underlying chronic inflammation. If it's rheumatoid arthritis, treat the rheumatoid arthritis. If it's tuberculosis, treat the tuberculosis. If it's chronic osteomyelitis, treat the chronic osteomyelitis. Moving on to the hereditary TTR, we spoke about this earlier. So this one, you're going to use tafamidis, and this helps to stabilize the TTR protein. And of course, there are also new medication like gene silencing. So you can use things like patisiran or inotersen. And then moving on to the last one, which is dialysis-related amyloidosis. So with dialysis-related amyloidosis, your goal is to switch to high flux dialysis or transplant for those patients. So going back to bortezomib, bortezomib is proteasome inhibitor. So by inhibiting the proteasome, right, that will lead to accumulation of those misfolded protein. Remember, we mentioned the job of proteasome in the previous lecture, which is where we destroy protein that are ubiquitinated. So if you ubiquitinate any protein, that means they are destined for destruction in the proteasome. So by inhibiting this proteasome, that leads to accumulation of misfolded proteins. And because of this accumulation of misfolded protein, this is going to trigger apoptosis, right, by activating the intrinsic pathway. So this triggers endoplasmic reticulum stress, and that leads to apoptosis, especially in cells producing high amount of the protein, example like plasma cells. And there's something that is really important. This medication is associated with herpes-zoster reactivation, and that's going to be a broad question. And in those patients, they need antiviral prophylaxis is recommended in those patients if they are going to take this medication. And guys, we've come to the end of today's lecture. So let's do some high-yield USMLE questions. So the first question there is: a 66-year-old man on hemodialysis for 12 years presents with worsening shoulder pain and severe carpal tunnel syndrome. Radiographs show osteolytic lesion around the scapula. A biopsy showed amyloid deposition. Which protein is most likely responsible? So based on history of dialysis for a long period of time and now amyloid, so this is going to be beta-2 microglobulin. So that will be dialysis-related amyloidosis. Moving on to the next one. So a 34-year-old woman with a family history of nerve disease developed progressive peripheral neuropathy and autonomic dysfunction, including diarrhea and orthostatic hypotension. Genetic testing reveals a mutation in transthyretin gene. Which treatment is most appropriate? So you need something that will stabilize those proteins in their tetramer state, preventing them to become a monomer. And that medication is going to be what? Tafamidis. Very good. Moving on to the next question. A 58-year-old man with multiple myeloma developed progressive edema, nephrotic range proteinuria, and kidney biopsy is performed. Which of the following microscopic finding is the most characteristic of this patient condition? So with multiple myeloma and now kidney failure and with nephrotic range proteinuria, so we're thinking of what? Very good. Light chain associated amyloidosis. So the best answer there will be C. Very good. Congo red positive with apple green bifluorengine under polarized light. Moving on to the next question. A 72-year-old man presents with progressive dyspnea on exertion and a lower extremity edema. He has no significant past medical history. EKG shows low voltage QRS complexes despite a thick left ventricular wall. So he has a very thick ventricular wall and a low voltage. So this is suggestive of restrictive cardiomyopathy, because if this is supposed to be high voltage with very thick left ventricular wall, then that would be hypertrophy cardiomyopathy. So the cardiac MRI reveals diffuse subendocardial late gadolinium enhancement and a no nephrotic syndrome, no neuropathy is present. So this patient have isolated cardiac amyloidosis. So a myocardial biopsy shows Congo red positive deposits, and a gene testing is negative for the TTR mutation. Which type of amyloid is responsible for this? So this is going to be the white type. Remember, we spoke about it. That's one that is more common in elderly. We also call it senile amyloidosis. So the best answer there will be B, which is ATTR white type. And moving on to the last question. A 55-year-old woman with chronic osteomyelitis due to poorly managed diabetes present with progressive lower extremity edema. So there's a chronic inflammation, which is chronic osteomyelitis. Lab show serum creatinine of 2.1, urine analysis show 4 plus protein, and ESR is markedly elevated. Kidney biopsy show Congo red positive deposit in mesangium and vessel wall. Mass spectrometry reveals deposition fibrins derived from acute phase reactant. Which change most likely preceded the development of this patient amyloidosis? So with this chronic osteomyelitis, right, now, like we mentioned, with chronic inflammation, right, so there's release of acute phase cytokine, which stimulate the liver to make acute phase reactant, and that acute phase reactant is serum amyloid. So the best answer there would be C. So elevated serum amyloid level due to chronic inflammation. So we've come to the end of today's lecture. Please don't forget to like, subscribe, and follow us on our social media platform and share with your friends. And I will see you guys in the next lecture. Bye for now.